Hi, everyone. Thank you for coming to tonight's webinar on the business of medicine. My name is Maggie Chung, and I'm the chair of the Communications Committee for the SIR-RFS. Tonight's webinar will be recorded and can be viewed on the SIR-RFS website. And right now, I will hand it over to one of our moderators for this evening.
Hi everybody, good evening and welcome to tonight's webinar. My name is Yuli and I'm a fourth-year medical student at the University of Illinois at Chicago, and I'll be introducing our presenter tonight. This webinar is supported by the Resident Fellow Student Women in IR Committee, and our mission there is to inspire, educate, and promote women in interventional radiology. I am honored to have the opportunity to introduce Dr. Geetika Klevos. Dr. Klevos is the Chief of Breast Interventional Oncology and Assistant Professor of Radiology at the University of Miami Miller School of Medicine. She completed her residency, fellowship in IR, and fellowship in breast imaging at Miami Miller as well. She also serves on the U of Miami Medical Group Council. Dr. Klevos has authored and co-authored several research publications, including her work in the treatment of metastatic colorectal cancer with drug-eluting beads, irreversible electroporation for pancreatic cancer, and image-guided cryoablation of breast tumors. So without further ado, please welcome Dr. Geetika Klevos for the Business of Medicine seminar.
Thank you, Yuli. Hello, everyone. Welcome. I am really excited to be here today and talk to you about this very important topic of the business of medicine. As doctors, I think we are especially naive in the business aspect of medicine when we set foot in the real world after training. This puts us at a big disadvantage and is partly responsible for the deteriorating state of physicians today, which is being dominated by administrative constraints in hospital-like settings. This presentation will hopefully be a stepping stone to initiate an interest in the minds of young physicians in training like yourself, and hopefully give you an edge in the future. No one teaches you how to think about money in medical school or residency, yet the moment you start practicing, you must think about it. This is by Dr. Gawande. So why do we need to know this? This is a presentation on teaching the medical students and residents the basics of business as they pertain to medicine. It is supposed to act as a primer to educate them so that they become astute in the principal key financial concepts. But wait a minute, won't we all be rich once we are attendings? The short answer is no. Financial IQ of Americans is really low and possibly lower among MDs. We are often seen as money targets and willing victims of financial scams, aka conned into buying whole life insurance. By the time you're attending, you have lost close to 10 years of salary and savings compared to your friends who got a job right out of college. Many of us have a high student loan burden and will start out attending life with a negative net worth. The goals of this presentation are to introduce you to this topic and hopefully instill in you a desire to learn more and take control of your finances, show you how to be able to become financially independent in about 15 to 20 years or less after residency, introduce you to a few things you definitely need to know about as you transition to residency and then to attending life. Disclaimer, we are not financial advisors. Take all this advice with a grain of salt. And this is from Bonnie Koo, who was a big part of this presentation. She is a dermatologist in New York. She and I collaborated on this presentation together. So this is from both of us. So according to a CNN Money article, doctors driven to bankruptcy. 5 years ago in Florida, which is where I am, there was a bankruptcy-based attorney, David Langley. He didn't have a single doctor as a client. Since then, he's handled at least 6 bankruptcy cases involving doctors. Now, none of those physicians had malpractice lawsuits that landed them in dire financial straits. All are top-notch doctors, he said. Lack of a basic understanding of running a business was a common theme for failed practices. What are some of the challenges facing new graduates? Declining reimbursements, we all know about that. Healthcare law changes, increased cost, contracts, leading teams, MACRA, MIPS, ACO. It's like a word salad of acronyms. And most of us don't know what they even stand for. So doctors are trained in medicine, but not how to run a business. In bankruptcy, everyone loses, the physician, the patients, and employees. So one of my goals is to hope none of you ever files for bankruptcy. Misconceptions. Mark Lyles, MD MBA, Senior Director of Healthcare Affairs at the AAMC, recalls of his days in medical school that whenever we asked a business question, we were always told, don't worry about that. You need to learn the medical side of it first before you ever worry about the business side. What students say. Medical student perceptions of education and healthcare system. This was an article in the Academic Medicine in September 2009. The study found that a large majority of graduating U.S. medical students from 2003 to 2007 were satisfied with medical school training in the domains of clinical decision-making and clinical care. In stark contrast, fewer than half of them felt that appropriate instructional time was devoted to the practice of medicine, especially the component of medical economics. So what can be done about this? There are a number of joint MD, MBA programs in America that's grown from 6 to 65 in 20 years. Maria Chandler, who's the president of the Association of the MD MBA programs, estimates that there are about 500 students in the joint programs across this country this year alone. The typical curriculum, year 1, you do MBA classroom work, year 2 and 3, MD coursework, year 4 and 5, a combined approach. But what about the 18,000 odd graduates per year without an MBA degree, who have an MD degree? If you search for business teaching in medical schools and residency, you're not going to come up with much. This suggests that there is a gap that exists that must be filled by organized medicine, county societies, state societies, specialty societies like SIR, AMA, AAMC. So these are the topics that I have prepared PowerPoints on, and these are some of the topics that you need to know. Now these are 5 to 10 minute long PowerPoints. What will be available to you will be PowerPoints, podcasts, and webinars on all these topics on the SIR website shortly, and I encourage all of you to go through them. They are short, like I mentioned, about 5 to 10 minutes long and easy to understand. This will serve as an introduction for what you need to know. It is going to be impossible for me to go through all these topics in 1 hour of today, so for now I decided to focus on something more personal that pertains to each of you, your finances. Steps you can take now, things you can do to strengthen your financial state while you are still in training. Loose ends you can tie up and prepare yourself by the time you get your first job. But the topics that I would encourage all of you to go through later on after we're done with tonight include retirement planning, investments, asset protection, estate planning, contract negotiations, private practice setups, managed care, account receivables, marketing your practice, disability insurance, life insurance, malpractice insurance, tail and umbrella insurance, what each of these are, what they do, ACA regulations like MIPS, MACRA, what they stand for, what they mean, electronic medical records, which is a nightmare to navigate, billing and coding, collecting, physician leadership, a very, very important topic, corporations, student loan debt management, all of us can know more about that, as I'm sure you agree, and RVUs. I also created a list of high-yield finance-related books, including The White Coat Investor, Business of Medicine, The Millionaire Next Door, Doctor's Handbook, 4 Foundations of Success, Boglehead's Guide to Investment and/or Retirement Planning. As you can see, a lot of these books are written by physicians for physicians. They contain simple, practical, and key financial advice. I have read all of them, and I would encourage all of you to read them as well. Irrespective of what stage of your career you're in, if you would like to be financially savvy and would like to end up with a sizable nest egg, this might be a good place to start. I do not have any conflicts of interest to disclose. I have no relationships with any of these authors, nor do I have any stocks in their businesses. The rest of the presentation is focused on the legwork you need to do and the financial guidelines you need to incorporate and adhere to before you start making any real money, so that by the time you become an attending, you are ready to manage your money and career effectively. Classic mistakes attendings and residents make: poor student loan debt management. They actually pay them in 20 to 30-year terms, forbearing during residency. Number 2, not living within their means. Number 3, not saving enough. Number 4, getting divorced. Number 5, not having enough insurance, whether it's disability, term life, malpractice, or umbrella. Number 6, buying a home too early and buying too much house. Number 7, loaning money to friends and family. Question, what does being rich look like? A, having a mansion, Porsche, luxury vacations yearly. B, sending kids to the top private school, but racking up credit card debt every month to keep up. C, bringing in bagged lunch daily to work, having a net worth of $5 million. Or D, buying a $3 million home when the combined income is $1 million. If you're smart, you'll go with C. Question, which of the following will help a person's net worth? Number A, a house. B, a fancy car. C, credit cards. D, $1,000 in a Roth IRA. Or E, what the heck is net worth or a Roth IRA? The answer is D. What should I save for during residency? A, 403B. Duh, I'll save on taxes. B, I can't. Residency is hard and I need to live a little and splurge. C, Roth IRA. Or D, none of the above. The answer is C. Student loans. If you have no student loans, consider yourself very, very lucky. If you're planning on having children, then you'll probably want to be able to have them be student loan free too, right? You'll need to save at least $250,000 for each of your children. Start your 529 accounts now. Make a plan to have your own student loans paid off by year X. I highly recommend you pay them off within 5 years. But of course, everyone's different. You get to decide your own number. Unless you're going to seek public service loan forgiveness, refinance them. Some banks will let you refinance as a resident and allow low monthly payments and interest that does not capitalize. Refinance or pay off loans that are greater than 6% interest as soon as possible. Generally, loans up to 3% interest can be paid off slower, to maximize savings for retirement, but do not let them become a family pet. You can find more information on student loans on these following websites. Why and how to save for financial independence. Social Security will be around but will account for only $30,000 to $35,000 a year of income if you delay full benefits to age 70. You'll likely have 20 to 30 years in retirement. Who wants to be working at age 65 or 70? Not me, I'll tell you. Medicine, unfortunately, is going down the tubes. Incomes are only going to decrease, as well as job satisfaction. Attaining financial independence will give you the freedom to punch out if you need to in the future. So how much do you need to save to be financially independent? General rule is to save 10 to 15% of gross income yearly. You may have heard that. Now, this applies to people who start working right out of college. For physicians, you likely need to save at least 20% of your gross income. Your retirement income needs will be much lower than your attending income. Scenario 1. Rebecca is 30 years old and married. She didn't start saving until she was 40 due to vacations, buying a home, having 3 kids, and enjoying life. She started saving $50,000 a year at age 40. Now, assuming a 7% growth, how much will she have at age 60? The answer is $2 million. Wow, that's a lot, right? Not really. Assuming she lives till at least age 85, that's $60,000 income a year for her and her husband, let alone helping the kids out. This is not including Social Security. By the way, she also has had $200,000 in loans and only paid minimums, and now has to ask her kids to help her out. Scenario 2. Sarah finished residency at age 30 with $15,000 in a Roth IRA. She saved 20% of her gross income, or $60,000, for 20 years. She got married and her husband was on the same page, and together they saved $100,000 a year. At age 50, they had $4.2 million saved, and she started working part-time because she had the freedom to do so. The power of compound interest. Let's talk about that for a little bit. You need time to harness the power of compound interest. $40,000 yearly for 30 years amounts to $1.2 million with no growth. $40,000 yearly for 30 years at 7% compounding annually is $4 million, or $2 million contributions and $2 million growth. Additional 10 years of growth with no addition at 7% amounts to $7.9 million. Delaying for just 10 years, you'll need to contribute $300,000 a year for 10 years to get to the $4 million, or $3 million in contribution and $1 million growth. Now let's assume a salary of $200,000. You put 20% gross income towards retirement savings of $40,000 yearly. $40,000 annually for 30 years at 7% return will give you $4 million at the end. Additional 10 years of growth with no addition at 7% amounts to $8.1 million. Delaying for just 10 years, $1.7 million versus $4.1 million if you did not delay. You'll need to contribute $96,000 a year for 20 years. That's 1.9 million contributions versus 1.2 million to get to the same 4 million to catch up. Strategy to reach financial independence. Emergency fund. All of you should have one or start working on saving up for one. 6 months of expenses, more if the spouse has an unstable job. Max out your tax advantage retirement accounts. What are those? 401k, 403b, 457b, 401a, traditional IRA, Roth IRA, taxable accounts. The above are all meant as investment vehicles. You should also have some money in cash savings. So how much do I need to reach financial independence? It's an individualized decision. It depends on anticipated expenses during retirement. Goal is to have no mortgage payments at financial independence. Determine your estimated income, say for example $100,000 a year for the rest of your life, and divide that by 0.03 or 3%. We'll get to that in a minute, how we got the 3% number. So for that $100,000 retirement income per year, that's 100K divided by 0.03, that's 3.3 million. That's how much you need to save. Why the 0.03? That's a 3% withdrawal rate on your total portfolio. This is the percentage you withdraw every year so that you don't run out of money. Most will say 4% is safe, but 3% is safer. Bonus, you'll also get an additional $30,000+ from Social Security. But what about the children? Now this is completely separate from what you need to save and spend on kids. Saving for them, for college, life insurance, etc., if you want to buy them any, is a whole other topic. Fund your financial independence first. Your kids can always take a loan for school. You cannot take a loan for retirement. The biggest gift you give to your children is your financial freedom. Let's talk about some pre-tax retirement accounts. Those include 401k, 403b, 457b. Now you can reduce your taxable income every year by the amount you contribute to these pre-tax retirement accounts. Now the 2016 annual employee contribution limit was $18,000. The employer can contribute the match up to a max of $53,000 total of the account. You pay taxes when you withdraw the money in retirement, but by then the advantage is you will likely be in a lower tax bracket. Every plan has different investment choices, or the really bad ones don't offer any choices. Now taxes can be a bitch as an attending. I pay more in taxes than what I made in my entire year as a resident. So that's why you have to try and minimize your taxable income. And one way to do it is by maxing out your retirement contributions to a pre-tax account. You also have the option of putting money into after-tax tax advantage accounts. Why I love the Roth IRA and the Roth conversions, because after-tax dollars go into the Roth and the money grows tax-free. No capital gains paid. No taxes when you withdraw the money in retirement, because it does not count as income. So Roth is a great way to go. As if you're medical students, once you become residents, you should definitely think of opening a Roth IRA. And for the residents and fellows currently, while your salaries are still less than $100,000, I would encourage all of you to open a Roth IRA and maximize. I think the max you can put in a Roth IRA is about $5,500 a year, and you should max them out every year. You may have heard of an income limit of about $115K. Now you can only open a Roth account as long as your yearly income is less than $115,000. That's what this means. Now, all of you will probably make more than $115,000 after residency. Now, this is true, but there is a totally legal way to get around this rule. That's also known as the backdoor Roth IRA. And what that means is you can convert any pre-tax account into a Roth, but you will pay taxes on that amount at your marginal tax rate. The other thing you might want to look into is the stealth IRA. And what is that? It's a health savings account. Triple tax-free accounts used to pay for healthcare expenses, or you can save it for retirement. It becomes an IRA at retirement age. But you must have a high deductible health plan to be able to do the stealth IRA. Taxable account is a regular brokerage account. After tax money goes in, you pay capital gains tax on gains when you sell the investments. Now, cash is cash, usually growing at an abysmal rate that is below inflation. Your emergency fund, which is ideally 6 months of your earnings, should be in cash in a savings account that is FDIC insured. For those that are married or planning on it in the future, choose your spouse wisely. Divorce is a financial catastrophe for physicians. It is very important for couples to have similar financial goals. It should be something that all couples discuss before getting married. All couples should have a financial plan. I highly recommend a prenuptial agreement, aka divorce insurance, especially if there are premarital assets, previous marriages, or kids. You should know the divorce laws in the state you get married in, and if you move. Why do you need insurance? You should insure against financial catastrophes, death, aka life insurance, disability, aka disability insurance, liability, that's professional, that's malpractice insurance, and personal, auto, home, umbrella insurance. Divorce, aka prenup, self-insure the rest, phones, appliances, but that's optional. Let's talk about the disability disconnect. Income is critical to most employees' financial security, yet employees rarely think about how an illness or an accident puts their income at risk. Learn the facts about the causes and odds of experiencing an income-interrupting disability. Doctors have to be in training for 8 to 15 years and often incur a high student loan burden. Weighing the odds. The chance of missing work for 3 months or longer as a result of illness or accident is far higher than most employees realize, especially when lifestyle, profession, and other factors are considered. Where many employees believe their odds of becoming disabled for at least 3 months or more are 1%, when in reality, more than 25% of today's 20-year-olds will become disabled before they retire. Time is money. A long-term disability can have a devastating effect on a person's financial situation. More than half the employees could not pay their bills for more than 1 year without an income. However, the average group long-term disability claim lasts about 2.5 years. Causes for concern. Employees may underestimate their risks because they don't understand the causes. 28% of all disability claims are due to muscle or bone disorders. Up to 15% are due to cancer. Accidents make up about 11%, mental disorders 9%, and cardiovascular causes are about 8%. Some factors that affect the likelihood that a worker will experience a disability of at least 3 months during his or her career, the percentages indicate the odds for a 35-year-old. Average weight or overweight. Average weight, if you're a non-smoker, if you do some office or physical work. Average lifestyle, if you have a generally good health history, that's the left side where most of you should fall. The average risk of a male becoming disabled is 24%, and for a female is 27%. On the other hand, if you're overweight, if you're a smoker, if you do mostly physical labor, or you have an unhealthy lifestyle or poor health history, your chances of becoming disabled for a male are 74%, and slightly higher, that's 77% for a female. Women have bundled risks. Women comprise more than half of the long-term disability claims in 2012. Pregnancy-related claims were the biggest contributor to the growth in women's claims. Common thoughts on DI. It won't happen to me. Fact, 1 in 7 will use it. Another common thought, I'm healthy, I have no family history. The fact is, not all cancers are genetic. Accidents are, well, accidents, you can't predict that. Myth number 3, I have coverage through work. The fact is most people have no idea what their work coverage actually is or isn't. Disability is complicated. Life insurance, well, you're either dead or alive. Disability, there's no time for disability. Disability is subjective. Policies start paying out at 30, 60, 90, or 180 days after disability is established. Disability insurance is more likely to be used than life insurance, believe it or not. And 10 to 20% of people between the ages of 25 to 65 will use it. Some of the things to consider are risky hobbies like climbing, skydiving, scuba, own occupation or specialty-specific definition, mental disorders or substance abuse. These are all riders that you should consider putting in your disability insurance. Residual disability, aka partial disability, the future purchase option, or cost of living adjustment. So when you shop for disability insurance, these are some of the things you need to discuss with your agent. You should also consider adding a non-cancelable and guaranteed renewable rider. The company cannot change anything about the policy, not the premiums, not the monthly benefits, and not the policy benefits up until the age of 65. Catastrophic coverage. Additional money above and beyond the disability benefit if your disability is so bad that you cannot perform at least 2 activities of daily living, such as dressing, bathing, toileting, or feeding yourself. Some of the occupational classes are as follows, that the way it's laid out in, when you go shop for disability insurance. Now, most fields of medicine are at a 3A or moderate risk of disability. Recommendations. You should all try to get a non-cancelable or a guaranteed renewable rider. Get the residual disability rider. Get the specialty-specific rider. So if I am a breast imager, I should get that rider, the specialty-specific rider or the own occupation rider. And that would mean if I'm not able to read breast imaging cases or perform breast procedures, then I am considered disabled and the company should pay me. Because what the companies can turn around and try to do is they can say, oh, but you're also a general radiologist, so what if you can't read breast imaging cases? As long as you can read general radiology cases, we're not going to pay you out. But if you have the own occupation rider, then they can't do that. So make sure you talk about that with your agent. You should also talk about the future purchase option, a cost of living adjustment, which you can cancel when you're older, that rider. And also talk about the catastrophic coverage. Buying disability insurance. You need blood tests and need to answer medical questions. Do this at the same time as getting life insurance because you can use the same set of blood tests. Women, I would highly recommend and encourage you to get it before you get pregnant. Buy it through an agent that can broker multiple companies so that you can get the multiple policy discount. Like I have my life insurance and disability insurance through the same company, that's MassMutual. So try to go with the big companies because they offer more stability. So either Principal, Emerita, Standard, Guardian, MassMutual. Premiums can really vary depending on who you buy from and what state. California is the worst, apparently. It has the highest premiums. These are some more resources on disability insurance. I have for some recommended agents. These are all active emails, so feel free to reach out to them. The first 3 are from Florida, and the last 2 are from New York, but anyone should be able to help you from anywhere these days. Let's talk about term life insurance. You absolutely need it if you're married, have children, or anyone else that relies on you. How much? It should be enough to pay your mortgage, student loans, child care, college, etc., funeral costs, loss of income due to a grieving spouse. You should go for ladder policies, which are to decrease after every 10 years. It's cheap, so just buy it. You need blood tests and need to answer some medical questions. That's why, like I mentioned before, do this at the same time as you're getting disability insurance. You can use the same set of blood tests. And women, again, get it before you become pregnant. I got my disability and life insurance when I was still a resident because your rates are much cheaper. But disability insurance especially, once you become an attending, for some reason your rates jump up. So try to get it when you are a resident, and you will see at least a savings of $100 to $200 a month which really adds up if you're paying for disability insurance up until the age of 65. And even though I got it as a resident, believe it or not, my disability premium every month currently is about $450. So it's not cheap, even though I bought it way back when. So the sooner you get it, the better off you'll be. I know some of my colleagues who waited until they became an attending, and they're paying up to $700 in premium every month for just for disability insurance. And I got my disability and life insurance definitely before I became pregnant, so I would encourage all women to do the same. Let's talk about umbrella insurance. An umbrella policy picks up where your other policies leave off. For example, if you purchase a $1 million umbrella policy, they'll require you to increase your auto and property insurance liability limits to at least $300,000. If there is an $800,000 claim against your homeowner's insurance, think about, say, a child who drowned in your pool. Your homeowner's insurance policy picks up the first $300,000, and the umbrella policy kicks in and picks up the next $500,000. Now, say someone gets hurt in your property, or you hit them with your car, and they go to the attorney on the back of the phone book. How long do you suppose it will take for the attorney to find out that you're a doctor? He'll likely discover most of your assets within a few days as well, and that's why you need to have an umbrella insurance policy along with those other insurances we talked about. Other insurances include malpractice, homeowners or renters. I hope all of you have auto insurance, and the prenup. Coming to asset protection. It is state-specific, but in general, retirement accounts are protected from creditors. Like Florida has the homestead exemption law, where if you do get sued in a malpractice suit, the defense attorneys cannot come after your primary home of residence. Then you should also look into asset allocation or title of assets, and that's something you need to discuss with your attorney or financial advisor. True stories. A female physician graduated residency and was diagnosed with breast cancer at age 37. But thank God she had disability and term life insurance, because she would not be eligible to get either of these if she had waited. Another story. A male physician suffers heart attack at age 50. Thank God he had disability insurance, because he had to use that until he turned 65. Another scenario, a female physician delays all this because she can't afford it. She gets diagnosed with lupus and now is no longer eligible for these insurances, or the premiums are just prohibitive. The last scenario, a female physician age 50 gets into a major motor vehicle accident. Now she's unable to perform surgery, and she did not have disability insurance. I get it, but this just seems like a lot of work. Should I hire someone? You can do it yourself, or you can hire a financial planner. Only hire a fee-only financial planner, not a fee-based. If you don't know the difference, you should look it up, because fee-only financial planners have to abide by the fiduciary law. And the fee-based are more commission-based, and they will try to sell you stuff and make a profit out of that. So you don't want to go with a fee-based financial planner. You should not go with someone who charges you a fee based on assets under management, and never hire a financial planner that sells any products like insurances. Please see Bonnie Koo's blog for the series on financial advisors. Yes, I have a financial advisor. What I do. I have a private owned occupation disability insurance. It's a principal unisex policy and a group disability insurance through the University of Miami, which is free. I have a term life insurance of $2 million, $1 million for 20 years and $1 million for 15 years. I max out my 403B and get additional employer match. I max out my 457B. Now these are all pre-tax retirement accounts because I'm trying to maximize my or minimize my taxable income. I fully fund a backdoor Roth IRA and a funded Roth IRA. I funded a Roth IRA throughout residency. I have an emergency fund, which is not quite fully funded at this time, but in the process of being so. I have no credit card debt, and I have no student loans. I plan to be financially independent in 20 years, or age 59, maybe earlier. Now, this could be you at age 50. I mainly invest in index funds, mostly Vanguard funds, through Fidelity. I have a detailed financial plan and my spouse is on board. Final words of wisdom. Live within your means. Live like a resident after residency for a few years. You can attain paying off student loans, starting your nest egg, and saving for a down payment, all at the same time if you follow the simple but hard to follow rule. Save early, save often. Max out your tax advantage retirement accounts. Learn how to invest properly. Make a financial plan. Fund your emergency fund of 6 months. I think it's okay to start with 3 months and then prioritize your retirement accounts. Contribute to a 403B or 401k, at least to the employer match. This is free money. I recommend fully funding this account. Fully fund a Roth IRA. Strive to save at least 20% of your gross income. Live like a resident for a few more years after becoming an attending, and beware of lifestyle creep. Resident financial health checklist. Figure out your student loans and a timeline to pay them back in. Figure out the total amount of your student loans, the type of loans, their repayment terms. Figure out what repayment option you should be doing, and you'll attack them after residency. Have a plan. Learn how to live within your means. Fund a Roth IRA every year of residency. You can max it up to $5,500 a year. Read at least one finance book a year. Consider it your financial CME. Purchase disability insurance and life insurance if you're married or you have children. Follow the blog. That's www.missbonnymd.com. If you have questions, you can reach out to either of us. Highly suggested reading. So what does the future hold? I would highly encourage all of you to educate yourself, familiarize yourself, and get involved in your finances, whether you stay in academics or go into private practice. I recommend all of you to go through these PowerPoints I mentioned earlier on the topics I listed, because those are high-yield topics you all need to know now. I learned the hard way, and I learned them later when I became an attending, but this is knowledge I wish I had when I was at your stage of training. In today's ever-changing, somewhat labile healthcare climate, now more than ever, it is so important for us as physicians to have a collective voice and the tools to deliver our message effectively so that we can protect not only our professional interests, but the interests of our patients, both of which appear to be in jeopardy. By collaborating our efforts and learning more about the business of medicine, we can hopefully steer the direction of where healthcare is going, get the power of medicine back in our hands, and bring back the joy of practicing medicine, so that the ones that follow behind us can think big, have a bright future ahead, because now more than ever, it's time for us to come together, and it's time for change. Thank you.
All right, thank you so much, Dr. Klevos, for that very illuminating presentation. I just wanted to open the floor up for questions now.
Sure.
And perhaps Maggie, if you're still there, I'm not sure what needs to be done for questions to be asked.
So anyone with a question, feel free to submit them through the chat, and we can read them one by one and have them answered. There's a chat box on the general webinar panel that you should be able to submit your questions. I was wondering if you could speak a little bit more about the backdoor IRA that you mentioned.
Yeah, so that's an option, you know, once you become an attending and you would like to contribute to the Roth IRA. When you get a financial advisor, you should talk to them more about it, and they'll tell you how to do it. You basically, you get to contribute to it, and then you get taxed on it in the end. It becomes a traditional IRA when you retire. And so, but the advantage is when you retire, you will be in a lower tax bracket.
Oh, okay. We have one question that was submitted. And the question is, wouldn't it be best to, sorry, one second, to contribute to after-tax retirement accounts, since we would be at a lower income tax bracket after retirement compared to during residency?
I'm not sure I follow. So the question is, when should you start contributing to the after-tax accounts?
Would it be better to contribute to after-tax retirement accounts?
So those usually,
like a traditional IRA.
Sure. So those usually become available once you become an attending, because as a resident, I did not have access or the option even to contribute to a 401k or a 403b or a 457b. Those options became available to me once I've started, you know, my real job as an attending. But what I did do when I was a resident is I opened up a Roth IRA, and anyone can do that as long as you make less than $115,000 a year. And I opened a Roth IRA in my first year of residency as soon as I was able to make even a little bit of money after med school. I opened up a Roth IRA. I contributed about $5,500 a year. So 4 years of residency, I had about $25,000 by the end. And now, even though I cannot contribute to it anymore except through the backdoor way, now that money is going to continue to grow till I turn 65. And it's so the power of compound interest, that's what I was talking about. So by the time I am done, you know, by the time I'm ready to retire, I'm going to have that pot in addition to my after-tax account, like my 403b and my 457b. So, and I don't even have to do anything for it. You know, it's just going to keep growing on its own. And the growth is going to be tax-free. That's the best part about a Roth IRA. So coming back to the question, the option of you being able to contribute to 403b and 457b will be available to you once you become an attending. I don't think you can do that before.
Great, thank you. And so Rupal was the one who asked the question. He had a follow-up. And his follow-up, he said, sorry, I meant post-tax versus a 401k/403b pre-tax.
So you can either do a 401k or a 403b and 457b. You cannot do all three. So what's available to me through my institution, and depends on, you know, what job you take and whether it's private, whether it's academic, and what options they provide. So it kind of gets limited by what your employer is offering you. So the options available to me through the University of Miami are 403b and 457b. And the difference between the two is, one of them, I think it's the 403b, is where the employer will match your contributions. So say you put in, you know, 5%, the employer matches up to 10%, which is great because it's free money. So you should try to maximize your contributions so that the employer can match it. And the other one, the 457b, the employer doesn't match anything. So you can, I think the limit is about, for 403b, it's about 18,000 what you can contribute every year. And I do that, I max it out. And then my employer matches about 35K additionally every year because of the 10% match. And so my total retirement through the 403B is about $50K a year, which is great. I don't have the option of doing a 401K. Now, if I was in private practice, I would get the health savings pension plan or something to that effect. And I think that would be, you know, the equivalent of a 401K or something like that, as far as I know.
Great, thank you very much.
Sure.
Okay, if there are no other questions, then, oh, actually there's just one more question. So as residents, would we not be able to ask our program or institution for any retirement benefits, such as the matching that you mentioned, or we just wait until we have a permanent employer?
Well, it doesn't hurt to ask. Maybe your program will provide you. I know the University of Miami did not have any options like that. I haven't heard of any options being provided to residents. I think you can contribute a little bit, because I was at USC previously and I was able to contribute a little bit to my retirement. And then what I did, that's the other thing I want to mention is, so say you switch residencies or you switch jobs, never withdraw your retirement savings. You should just get them rolled over to the next job's retirement savings. There's a rollover option. I would highly recommend you to do that, because that's what I did. I rolled whatever savings, it wasn't much, but whatever amount I had saved in California, I rolled it over to my health retirement account when I came to the University of Miami. So yeah, you can ask your program if they will let you do it or if they will contribute anything, but the answer may be no.
Okay, great. So I think at this time we'll wrap up the webinar. Thank you so much for such an informative and helpful webinar this evening. And thank you everyone for attending the webinar tonight. The video will be recorded and uploaded to the RFS website.
Sure, you're very welcome. Thank you for listening.